Good afternoon around the world. Welcome everyone to a Meet the Expert session on renal replacement therapy. I'm John Kellum from the University of Pittsburgh, and I'm joined by my good friends Marlies Ostermann from Guy's and St. Thomas's in London, and Professor Claudio Ronco from Vicenza and Padua, Italy. We hope we have a very provocative discussion amongst the three of us. I see there's already a question from the audience, and I'll just read it and see who wants to answer it. It's not clear that it's directly related to CRT, but I think it will work. For how long do you give Lasix's therapeutic test time? And I think the questioner is asking about really a broader question about how might you use diuretics to sort of probe the necessity for renal replacement therapy. So who wants to tackle that one?
Well, I can say what I do, and it is basically the fact that we are well aware that diuretics do not affect outcome or change the history of AKI, or even less provide recovery of renal function. However, they may transform AKI from oliguria to non-oliguria, which is easier to manage, and it is always good in presence of an adequate hydration to provide a diuretic test. Of course, after 6 hours, if this is not giving a good result, I think that in oliguric patient, the choice will be to move to extracorporeal therapy.
So for that, Claudio, you might, just for example, do you give a fixed dose of furosemide, or do you give a dose relative to the weight of the patient or other parameters to decide? And you said wait 6 hours. Is that a sort of a fixed rule in your mind, or?
We do not have a fixed rule. We normally consider that we don't want to go to a higher dose in a 70-kilo patients. We don't want to go to a dose higher than 1 gram. And in some patients, however, we may distribute the infusion over hours in a continuous mode. And especially in cardiopathic patients, we have seen that this may have a different impact compared to a single bolus. So we judge very much the pathophysiology, the type of patients, and based on that, we try to adjust in a personalized fashion the diuretic therapy.
Marlies, anything to add?
So we give. So I tend to give smaller doses. So I would only consider furosemide in patients who are fluid overloaded and have no other indication for renal replacement therapy. And I would consider furosemide or Lasix or a diuretic in patients where where I had enough room in case the diuretic doesn't work, so it wouldn't give it in refractory pulmonary edema or any life-threatening fluid overload, just in case the diuretic is not effective. And then we start with lower doses. We start usually with either 20 or 40 milligram bolus doses. We may escalate them to 80 or 100, but in the intensive care unit, 80 to 100 bolus doses are the maximum in our practice. If a bolus works, and there is an appropriate diuretic response and there is no indication for renal replacement therapy, then and there is still fluid overload which needs to be corrected, then we would either continue with regular boluses or switch to an infusion. And if we give an infusion, again, we would only give it until we are sure it's working. As soon as there's concern about refractory edema or harm from fluid overload, we would switch to other modalities, so extracorporeal technologies.
If I may add something, we did a consensus conference in London some years ago, and together with the ADKI group, we published a kind of an algorithm, I think, in blood purification, if I'm not wrong. And the algorithm describes very well who are the patients in which extracorporeal fluid removal, I would not call renal replacement in this case, I would call extracorporeal fluid removal or ultrafiltration, is indicated in case of conditions refractory to diuretics. So I invite everyone to go back and see this algorithm that has shown to be working over the years, at least as a guide for indicating the application of extracorporeal therapy.
Yeah, and I think I just in terms of closing this one out, I feel like I'm sort of somewhere in between you two in terms of aggressiveness of diuretic use. I tend to give a bit higher doses than Marlies was describing, maybe as much as 200 milligrams of furosemide, not more than that though, and relatively quicker evaluation. I think people who don't respond in 3 or 4 hours to that dose of furosemide are generally not going to respond, and therefore, rather than give them more, I would tend to move toward renal replacement therapy. Now, I think this is a good segue toward, I think, what's probably the most controversial issue in our field at the moment. See if the two others agree, but this notion of timing of initiation of renal replacement therapy. And of course, timing builds together with patient selection, right? So some patients, the timing is never, and some patients, the timing is ASAP. And then there's a group of patients that are sort of in the middle that I would argue are, it's unclear whether you should initiate renal replacement therapy as quickly as possible, or perhaps wait for some indication that the patient's requirement for renal replacement therapy is greater. So obviously, this has been studied in the START trial, which like other trials, like the Akiki trial, for example, have demonstrated that in the group of patients that are sort of in the middle, there's not a clear advantage to either waiting or starting early. And so I'd like to maybe have some bit of discussion about that.
You want to start, Marlies, this time?
Sure. So the START AKI trial obviously showed that there was no difference in 90-day mortality between patients who received accelerated initiation of renal replacement therapy compared to standard initiation. Now, the key part is obviously that there was a pre-selection process. So patients were only eligible to go into the trial if the clinician treating the patient had sufficient equipoise. And therefore, patients with an indication for immediate renal replacement therapy, according to the clinician, who obviously, and patients therefore who could not wait for at least 12 hours, according to the clinician's judgment, were not eligible. Similarly, patients where the clinician felt that renal replacement therapy was not indicated and renal recovery would occur very quickly, again, they were not eligible and were not randomized. And I think that's quite important, that clinical judgment was a condition before patients went into the trial. And so a lot of patients were already selected out beforehand based on clinician judgment. And the only group of patients who went into the trial were those where the clinician treating the patient at the time felt they would be happy with either way, early versus late. I think that needs to be remembered, and that is different from many other trials like the IDEAL ICU or the Akiki trial, which obviously got criticized but people said, well, they randomized patients to the early arm who would have recovered anyway, or to the late arm who should have had renal replacement therapy very early. And I think this needs to be remembered because people have misinterpreted the START AKI trial as saying you can wait until there is an absolute emergency indication, which I think this is a wrong interpretation. Claudio?
Okay. I think that there are questions that can be answered by randomized trials and questions that probably cannot be answered by randomized trials. And in spite of the good design of the START trial, and also we should not underestimate the previous studies that were well conducted, I don't think, honestly, that this is a question that will be solved by a randomized trial. And the reason for this is that in the last 10 years, we tried to study the level of concordance between the nephrologist and the intensivist at the bedside of the patient about delaying or starting immediately a renal replacement therapy. And the level of concordance was, in most of the cases, 98%, and the 2% was utilized to refine the discussion, finally leading to 100% concordance. So I don't think we will ever have a number that will tell us when to start or not. I think that more than clinicians, this number is sought by insurance company, by administrators to declare, in some cases, what is a futile treatment compared to what is a necessary treatment. But it is absolutely difficult, I think, to establish and generalize to the overall population, not to a population selected by a randomized trial, what is the reality. Because from the studies, people tend to read the title, sometimes the abstract, almost never the entire study, and they do not appreciate that this was, as Marlies said, a specifically designed population. For all the others that do not have equipoise, there is no discussion. So the problem is how many in the ICU have equipoise? Maybe 20%, 30%. So is this representing the majority of patients? I don't think so. This is my view.
Yeah, and I think you guys are saying the same thing. And I think I agree that the difference between the question that the investigator set out to answer and how the answer is perceived is often a problem, right? So when people interpret these trials as to suggest that timing of renal replacement therapy doesn't matter, that's the wrong message, because if a patient needs emergent renal replacement therapy, the timing is critical. Equally, I think many of us were curious whether or not, and this goes back several years now, but whether or not these patients that don't have an urgent indication, not even an urgent one, far less an emergent indication, but even an urgent indication for renal replacement therapy, such as positive fluid balance, but not pulmonary edema, at least not severe pulmonary edema. And they could reasonably be managed without renal replacement therapy, but you always sort of wondered about these patients. Did you benefit them by this sort of conservative management? It felt like they stayed in the ICU longer. It felt like some of them you wound up doing renal replacement therapy later, and then you wondered if I should have done it sooner. And so I do think, that the numbers probably were exactly what Claudio said. I think they're kind of 20 to 25% of our patients. And for these patients, we really do want to know whether we've waited too long or whether we're being too aggressive. And if anything, the results suggest that we may be calibrated just about right, because for that population, there doesn't seem to be an advantage or disadvantage, at least not a major one, for initiating or not initiating. But one thing I do want to suggest to you is that within this group of patients, there are winners and losers. There are some patients that were given a wait and see strategy. They were randomized to wait and see, and they were fortunate. They recovered renal function. They never received renal replacement therapy, and they had a good outcome. There were other patients that were randomized to that group that wound up getting renal replacement therapy late, and their outcomes were not as good. And then there's the early group that included a heterogeneous group of patients as well. Some probably never would have received renal replacement therapy if they were in the other group, and therefore received an invasive therapy that it was unnecessary. And others would have wound up getting renal replacement therapy anyway, and therefore earlier therapy in that group may have been beneficial. And I think we have only one study really of all the trials out there that have tried to answer the timing question as opposed to the decision-making question, which are two different things. The timing question asks, if you're going to do renal replacement therapy anyway, does timing matter? And that was a trial conducted by Alex Zarbach, which showed that early initiation was superior to late initiation. And then all the other trials have said, when you don't know, when you have equipoise, does early initiation benefit? And the answer to that is no. And those are two different questions, and I think we have to wrestle with that. Yep. The question that was typed into the system was very much related to that, which is, does early renal replacement therapy in sepsis without severe uremia or acidosis lead to a better outcome? And I think, we don't have studies specifically in sepsis, but sepsis is a good example of a patient population that may not have some of those patients may not have an emergent indication, but if you wind up having to do renal replacement therapy later, those patients may benefit from receiving it earlier. On the other hand, we need to recognize that we're not very good at judging whether patients will go on to develop a need for renal replacement therapy. Now, of course, Marlies and Claudio are very good at making that decision, but it's hard for clinicians, I think, to decide.
No, I may say that we're not particularly good, but we are certainly exposed to this question. And I think what we need, in fact, is a better tool for biomonitoring of this patient, getting more information about the evolution, about the genotype and endophenotype and evolution of the disease. Nevertheless, I think that there is a discrepancy between what people write in papers, which is there is no evidence that support the use of CRRT in septic patients with no AKI and so on, and what people do. And the common experience is that when you have a septic shock and these patients are placed in extracorporeal therapies, a few hours later you remove or cut 1/2 of the amount of norepinephrine that you give to the patient. So there is something, once more, that requires some evidence, but we have to ask ourselves if we will ever be able to get the level of evidence that the skeptical people want. And I am honestly surprised by the fact that there are other practices in the ICU that do not have high level of evidence and are normally conducted. And I don't understand why extracorporeal therapies are always so much scrutinized and focused for getting the evidence. So this may be an Afrocentric view because it introduced another concept. What is the risk for an extracorporeal therapy? And here we have to bring up the question that partially John alluded to. if we have an overhydrated patient and we know that overhydration is a cause for increased mortality, and we are not able to manage this conservatively, we may want to remove the fluid overload by extracorporeal therapy. But again, we have to be able to do it well, because if we're not able to do this well, we probably may cause more damage than benefit. So what is often neglected is the quality of the intervention, that in different centers may be very different. And the final thing is, when you do a study, you have to consider what is the mortality in the control group, because most of the interventions show benefit when the mortality in the control group is very high. And this is extremely important because it leads to the concept that you need to select the population where you do the study and where you try to apply your intervention.
Yes, I think that's a very good point. And I think the theme that's sort of arising from this discussion, relates to the role of randomized controlled trials. It relates to the role of, clinical judgment. It relates to the role of the interface between the indications for the technique, the skill of the person providing the therapy. And I just want to make a comment related to that, which has to do with the fact that one of the concerns that one has in initiating early renal replacement therapy is that you initiate it with some patients that may not benefit because they would have recovered. But in the group that you delay renal replacement therapy on, some of those patients may require renal replacement therapy under emergent conditions in the middle of the night, maybe with elevated potassium or dangerous fluid overload and edema. And we have evidence that those patients don't do well either. And so a lot of clinical judgment needs to be enacted, I think, to be safe for patients. And I think, back to Claudio's original point, the residual number of patients who, at the end of the day, you truly have equipoise on ends up being, I think, a smaller number, which is why I think the trials have needed to be, many centers to get adequate patients. All right, so there's some other questions on the Q&A. I'd like to try to bring in the last 7 or 8 minutes that we have. They're far ranging, and so I think trying to pick out ones that seem to be repeated a bit. This one may be for you, Claudio. What is your opinion or experience about using special filters during renal replacement therapy to remove interleukins and cytokines and things like that? So I think we're specifically speaking about modified filters or high flux filters or high porosity filters. What are your thoughts about that?
Well, once again, I cannot quote randomized controlled trials, but I have spent almost half of my academic life trying to develop devices and membranes that have a specific permeability and capacity to remove solutes. So today we have a bunch of new sorbents, we have a bunch of new membranes, medium cutoff, high cutoff, or membrane that are functionalized on the surface with vitamin E or absorbing heparin and so on, that have a specific rationale for the application in specific patients. I think that what we need to do, because we're not going to be able to do randomized trials, is to try to identify criteria for applying this specific type of membranes and type of devices. In particular, I'm referring to the potential of a sequential extracorporeal therapy in sepsis, where you have a cascade with presence of bacteria, presence of endotoxin, and then presence of mediators, and then organ damage. If we can identify and monitor biologically these windows in terms of times, we will be able to apply in a very effective way the removal of endotoxin. We will be able to apply devices for removal of cytokines. And this specific removal has been suggested to work well because of the peak concentration hypothesis, because to stop one single cytokine may not be the answer to a very complex system. So I am strongly in favor, because I remind you that originally people were skeptical about continuous renal replacement therapy. And even longer ago, they were skeptical about dialysis. So I think that we should move in a further generation of devices and extracorporeal circuits. However, we need to make them available to everyone to become somehow a routine. So work on costs, work on safety, and possibly work on a new generation of machines that are platforms capable of doing almost every kind of therapy. I understand that this is a view probably of an advanced center and advanced research center, but however, we should consider that research has always anticipated what then becomes clinical routine.
Thank you, Claudio. Marlies, you have any comments on that?
No, I agree with Claudio. So to date, no randomized controlled trial has shown a benefit, has confirmed a benefit with the use of these membranes. But in theory, yes, they in animal models and in studies where they were tested, they indeed showed the removal of certain substances, but we've not had any trial confirming that this translates into different patient outcomes, and that's the trouble.
Yeah, and I guess I wonder whether the solution.
The question is whether mortality is the endpoint for these studies. If I test something that should be capable of keeping stable hemodynamics, this doesn't mean that it affects mortality. It depends on the subsequent intervention that you can apply, but at least you gain time to apply the subsequent interventions.
Yeah, I think that's one outcomes and endpoints for clinical trials have been one area where we've maybe not been as sophisticated as we could be. I would argue, though, in addition, study design is a huge problem. And I think what you end up doing in randomized controlled trials too often in our field is that we know that we would really like to study a very specific group of patients, but we can't enroll that very specific group of patients. So in order to make the trial feasible, we expand to a group of patients that are phenotyped in a way which allows the trial to go on, but doesn't actually enroll patients that we're interested in treating. So for example, we would enroll patients with sepsis or septic shock, recognizing that we only know a fraction of these patients actually have high cytokine levels that we really think would benefit. And when we do that, we can run the trial, but the trial is almost always negative. And to me, it's a bit like saying, I'm going to do a study of high-dose insulin versus low-dose insulin without ever measuring glucose or caring how high the glucose is. It's a study designed to fail. And unfortunately, our field has been a bit naive, I think, about just thinking if you could just randomize enough patients, you'll be able to evaluate anything. And I think the answer is if you just randomize enough patients, you'll be able to prove that nothing works. So I think it's time. It's we're approaching the year 2021. Eventually, COVID will be behind us and we can start thinking about other things again. And I think one of the things that I'd like to close on is just a better way of doing clinical trials that are informed by what we know and not by what we can do. There's an old adage about the drunk who was found, half a block from his car looking for his keys under a street lamp. And he was asked why he was looking here. And he said, well, this is where I can see. The street lamp is lighting the road. And so that's kind of what we've been doing with clinical trials, and I think it really needs to end. So I'm taking the moderator's privilege and having the last word, but thank you very much, Marlies and Claudio, and thank you to the audience. I realize there were many more questions than we could get to, but I think some of this discussion has generated, I think, the answers to many of the questions that people have. So thank you very much.
John?
Thank you.
We may say that we will continue the discussion at the Vicenza course in 2 months.
Very good. Excellent. Ciao, everyone. Bye-bye.
Bye.
Thank you.